So we've been talking a lot about talking, and now I'd like to talk a little bit about chemistry.
Yes.
Drugs.
Yes.
So maybe first we could talk prescription drugs. I mean, you're a psychiatrist, so you're approved to and presumably do prescribe medication where appropriate. I mean, this is a vast landscape, of course. We've got ADHD. And I should just tell you, I get more questions about ADHD and the drugs related to ADHD and dopamine than any other topic. Any other topic. So there's ADHD, there's OCD, there's depression, there's antidepressants and so forth. Is there some way that we can wrap our arms around all of that as a way of wading into this drug question and just address, how does one decide when medication is useful? Because in the end, the dissection tool that the psychiatrist or therapist has is language. And at some point, one has to make an assessment about dopamine or serotonin or whether or not a given drug would help. And most therapies, I believe, don't involve putting someone in a brain scanner. And to my knowledge, there still is not a very good blood test to assess, is this person's dopamine low or high? Correct me if I'm wrong. And ultimately that, and I know there are companies out there, so I'm not trying to undermine those companies, but if I happen to do that in this statement, if you take a blood test and find that your serotonin metabolites are low, my understanding is it's possible that you are too low in serotonin in the brain, but that's a very indirect window into what's really going on. So how do you think about prescription drugs in the context of treating trauma and other conditions? And then maybe we'll drill into some of the more specific conditions.
Sure. I mean, I would first comment that, there aren't tests for these things. And I think the tests for metabolites, things are so different, by the time what we're talking about has been metabolized, often to some very significant extent, left the brain, now it's in the peripheral blood, that we really don't learn from that. Right? I think that we tend to overutilize medicines in this country because we have a healthcare system that often that's so based on throughput that we want to polish the hood when there's a problem in the engine, right? So we overutilize medicines often as an endpoint, right? We're going to make that person's depression better with an antidepressant. Well, maybe, right? But most of the time, for that person's depression to really get better and stay better, they need to unravel what's driving the depression, right? So the first step is, I think there are kind of two steps to it, right? The first assessment step is there a diagnosis that the vast majority of the time, if not sometimes all the time, really warrants a medicine? So bipolar disorder, OCD, ADD, right? These are diagnoses that we understand more about them and what's going on in the brain and how medicines can treat or stabilize them, which doesn't mean the medicine is it's not a substitute for therapy, right? But sometimes the medicine and therapy can go hand in hand. So for OCD, for example, it warrants therapy, but it almost always warrants medicine too, so that you can ease the systems that are making the rigidity and the repetition in the brain. So the first kind of branch point can be, what is the diagnosis? What is the level of severity, right? And I think that's very, very important. Where I think it's a little more, maybe even interesting, is using medicines to help the person engage in the therapy as productively as possible. And here's where I think we're so limited by how we categorize medicines and this sort of pharmaceutical, insurance-driven medical system we have that I think throws us off in tremendous ways. So you think about how medicines are categorized. So antidepressants. And the vast majority of people who are helped by antidepressants, they don't have clinically severe depression, right? Those medicines create more distress tolerance in us, right? And if you think about how helpful that can be, if you're going to go, now you're going to do something difficult, right? You're going to bring that trauma or those stressors to the surface and you're going to process it and you're going to try and make life change. If we can make more distress tolerance in us, that can be so much better, right? And think about the category of medicines that are called antipsychotics, which really puts people off, right? But most of the prescriptions for antipsychotics are not for psychosis, right? And there are ways in which low dosing of some of those medicines can help intervene in negative pathways, right? In pathways that are about distress and, sending out those tendrils of neurons that are about hypervigilance and avoidance, right, in our brain. And we can often get at that. And if you can improve someone's distress tolerance, and you can use medicines that take away what clinically is rumination, right? Not the standard meaning of that word, but the clinical meaning of it, where there are distress centers in our brain that are overactive, and then we get stuck in these maladaptive negative pathways where we think about something over and over and over again with no real chance of solving it, because that's not what's going on inside of us. So medicines can help that, but we have to have some flexibility around their conception. And the modern medical system of 15-minute visits, to a psychiatrist that are weeks apart. I mean, I don't understand how that goes well, right? In the vast majority of times, I think it doesn't go well because it's not enough time to do the therapy, to even generate the understanding. So then medicines get thrown at the person. And this is how, we use, I think, approximately 5 times as much medicine, I think, across the board as, say, the Dutch population, right? And you think, well, why is 5 times more is a lot more medicine, right? And they have a healthcare system and a cultural system that, to the best of my understanding, is more rooted in taking responsibility for oneself, right? So if a person comes in and cholesterol is high, right, the first order of business is, hey, you take better care of yourself, right? Like, this person really needs to lose some weight, exercise more, right? They're not just jumping to, like, let me give you a medicine and shift you through the healthcare system and out the other side of the door, right? And the same thing is true in mental health. And I'm not trying to be critical to the psychiatrists or the nurse practitioners, the people who are practicing in that way, because oftentimes there is no choice, right? If they're working in a healthcare system that the standard is highly spaced or spaced apart 15-minute visits, what alternative is there, right? But to look at, okay, I'm going to use medicines because I don't have another tool to bring to bear. So I think the healthcare system and its focus on throughput and its short-term, we talk about short-term response, right? Short-term soothing at the expense of long-term health. And I think that is the metaphor that applies to our healthcare system, right? Where if we are going to try and treat a symptom in a short term, we're going to do it in a 15-minute visit, that we're going to do it in a way that maybe it soothes the symptom, maybe it doesn't, but it does not get at the problem. We need to invest more resources to get at the problem. And I think that's where a sort of protest, if people as a society, we say, look, we don't like the way our healthcare is going. Like, we need more focus on what the actual problems are, that yes, we would spend more money, treating people and taking care of people because it's more human time, but ultimately about less suffering, less death, right? And ultimately more productivity. I think as an economy, we would save so much money if we spend money on the human aspects of mental health care, because people would be more functional. They're spending less time in the hospital, right? They're more productive when they're working. There's less entry into the criminal justice system. So I think medicines get overused in part for systemic reasons, in large part for systemic reasons, and also for some of these categorization reasons. Oh, that person meets some technical criteria for depression, we got to give them this medicine, instead of really thinking, wait, what's going on in this person? And I see this over and over again. I see someone who's on 7 medicines, and they're on 7 medicines to treat 7 different symptoms, and now they have side effects from all those 7 medicines. Maybe 2 of them are to treat the side effects from the other 5, right? And that's bad, right? And if you really get at what's going on in them, now they're doing much better, and maybe they're on 2 medicines, right? So I don't know if that's a helpful answer to that.
It is. It's a very helpful answer. I mean, I think at least in the spheres that I run these days, I hear a lot of negative statements about antidepressants. I think, I'm old enough to remember the book Listening to Prozac, and I remember when Prozac and its and things like it first started showing up, and the excitement. And then nowadays I hear more about the problems with all these drugs, and maybe that's just because I have arms in both the scientific, but also in the kind of wellness community where people think a lot about behavioral change. Fortunately, I think that they do that. But of course, these drugs, as you mentioned, can have enormous utility as well.
Yes.
I'd like to just pick up on one theme that I haven't heard a lot about anywhere else, which is the short-term versus the long-term use of these drugs. Because I could imagine, someone feeling like they're finally going to tackle something that's been inside them for a long time, either because they're really struggling or because they're just done with not working it through. And they decide to start a medication that would give them higher levels of distress tolerance for a short while. I mean, is there anything to say that someone couldn't take a properly prescribed medication for a week or for the first 3 months of the work, and then know that they can come off it? Because I think that the black and white model of, okay, you're either going to start this drug and stay on it forever, or be taking some drugs forever, or you're not going to take anything. I mean, that just seems life doesn't does life have to work that way?
Right.
Is there short-term use that can be effective?
Yeah, absolutely, yes. Yes, in American medicine, we are so much better at starting medicines than we are at taking them away, right? And part of that, I think, is driven by such a strong presence of the pharmaceutical industry. And look, the pharmaceutical industry does a lot of very good things, right? But there's such thing as too much of a good thing, right? And then as a society, when something seems positive, this I think also is human nature. We can overinvest in it, right? So if you think about when Prozac and those kinds of medicines came out, they were safer medicines. They're billed as antidepressants. And the thought was, well, they're going to fix depression, right? And it's not how that works, right? So if we look at them as tools, right, then we can deploy them sometimes for the longer term, because sometimes that's necessary, but absolutely for the shorter term. I mean, absolutely. If we thought of Prozac and those kind of medicines, not as, oh, they're antidepressants. We thought, look, what they do is they seem to make there be more serotonin in certain circuits that are important for mood regulation, anxiety regulation, distress tolerance. So those medicines can really help somebody if they're very severely depressed and we want to sort of get them feeling better. They can also help someone if they could use more distress tolerance in a discrete period of time, right? When we think about them that way, we think about them as tools that we could apply for short-term or long-term. We don't see them as fixes, right? And we don't see them as then substitutes for the human-to-human work that needs to be done. I mean, I've been in my training at times in healthcare systems, and I've seen in many other circumstances that look at medicines as answers. And this idea that, oh, that person is and a lot of times there'll be a number, right? And the number is the diagnosis, and that number gets this medicine. And I'm not sure we could be more misguided than that. And that's what leads to adding medicines. It's not working. Of course it's not working, because no one's really paying attention to what's going on. So add more medicines and then medicines for the medicines. And I mean, we know this is true. We know this is true, but we haven't had the wherewithal as a society to say, with a lot of things in society, to say, this isn't okay. Right? I mean, we need more. Give these people who are trying to help us, they need more latitude to help us. We need more human-to-human contact to get at what's really going on. And yes, that's an investment of time and energy and money in the short term. And sometimes that's money from the systems, right? But if we do that, my goodness, look at the payoff of that.